Colleagues, let's reconverge for our next session. And I want to call upon the presenters to be stepping forward. My name is Dr. Richard Mugahi. I'm introducing myself as the session chair who is going to take you for this afternoon session. And I would like to invite our presenters to step forward, actually sitting on the front chairs, and then we should be starting shortly. Can we have the chief whip get people back? There are so many behind there. I had requested that they combine lunch and breakfast, but that wasn't possible because it's a quality improvement procedure. In the interest of time, I would like to request that Dr. Nyeko Filbert, Hospital Director Kabale, takes the front seats. Wangobo Ayub, DHO, also one of the presenters, step forward. Naluge Prose is already here. Thank you, Prose. Lajara Betty is not yet here. Is already here. The ladies are really QI sensitive. Amito Janet, quite packed, but if we can have the presenters in front, then I'll definitely allow them to begin. We have 1 hour for 6 presentations, 10 minutes each. So it's going to be the most important message you want us to pick and where you think the change has occurred. I have seen my friend Dr. Nyeko is already here. Those who are standing, please take your seats, or you go and stand outside, but it's okay. But I would request that we take our seats and listen to the first presenter. Dr. Nyeko Filbert is our first presenter, and he will be presenting functionalization of quality improvement structures in the region for improved health outcomes. I expect the technology to be doing the needful, and we don't have much time to spare. Dr. Nyeko Filbert, and let's step forward and make your presentation.
ICT. Thank you very much. Ladies and gentlemen, good afternoon and welcome back from that tea. My name is Nyeko John Filbert, and Hospital Director Kawale. I'll take you through functionalization of quality improvement structures in the region for improved health outcomes. If that is agreeable, I proceed. That red spot at the lowest point of Uganda, left bottom corner in red is the Kigezi region where we work. Some 410 kilometers southwest of here, we also border DRC and Rwanda thereabout. Enlarging those districts, we are 6 districts there, composed of Kabale, where I sit, Kisoro, Borobanda, Kiga, Rukunjiri, and that's the group of people we serve. The hospital is not so big. Looking at it from above, that's what you'd see. We have about 280 beds congested in a smaller area. It's not actually the capacity. And so far, we have a 66% bed occupancy rate with an average length of stay at 5 days. So we're serving quite a number of people. By way of introduction, I'd like to tell you that yes, we have come here to look at quality improvement. Everybody is doing that. And this particular one, we are interested in how the components of effective implementation of quality care can help us improve. The QI structures serve as mechanism for coordinating 5S, quality improvement, related activity at each level. I mean all health facilities. These structures include the regional QI. We have the regional referral hospital QIs, the district QIs, and the health center QIs. They are abbreviated differently. The thing is not changing. Would you like to shift that slide forward? Yes, the quality improvement requires active and continued support from top leadership. We had somebody present, professor presented and told us about the role of leadership in the QI improvement. In the region, we have especially the leadership at the districts, the chairpersons, the chief administrative officers, the DHOs, the team in the regional hospital headed by the director, and each of these have a key role for us to be able to improve the quality in the region, and therefore must participate in the initiatives. In Kigezi, we have tried to build up these QI structures from health center 2s up to the regional referral hospital level. At the start, our problem was that out of the 6 districts, only 4 had active district QI committees functional. And the regional QI was not doing its role of support supervision and were not being able to perform joint review mission. We had no quarterly district improvement committee meetings, and we had assessments, and we also had limited initiative at the regional referral hospital to discuss the regional health. And therefore, we had to conform to what the national level says, that we should be holding support supervision and regional quality improvement. In the process, we had to get around those problems. As I said, they were there. The few functional district QIs, we had no support supervision, we had no joint review mission going on, and we had no quarterly district QI assessments, and so very little initiative. We had to identify stakeholders for the regional QI committees. We designed and issued appointment letters for the regional members. We also mobilized funds for convening regional QI committee meetings and the regional joint performance review missions. We identified and trained district QI focal persons, developed work plans for the regional QI committees and the district QI committees. We had quarterly assessments of regional QI structures, and we also went out to benchmark and see how it is done elsewhere. After doing that, that's what we came up with. At the end of the day, as I speak, by today as I speak, we have all the district QI committees functional. We have 90% of the regional QI committees in functionality as of Q3 last year. And then we have the district QI committees assessment being conducted at least in 50% of the cases. All our districts now have the district QI committee work plans. Ladies and gentlemen, from that little approach, we can see that there has been progressive improvement in the regional QI committee assessments, rising from 85 and now we are at about 90. We think we could do better, but we also have other system issues that are tying us down. The district QI assessments, or QI committee assessments were also done, and if you look at it carefully, we are not yet there, but most of us are scoring above 50, and that means we are progressing and we are doing fairly well. During our GRM, one of the biggest problems we got was with assessment of TB at OPD. We embarked on this, and in the process, we can also see that we improved in that. And most importantly, and perhaps what you need to see, is we are serious and we would like to have our gene expert utilized. Do we go anywhere? Yes. The ranking of the league so far has enabled us that because of this initiative, we have at every one time 3 of our districts in the top 20 of our league. And at any one time, we will have at least one district either being number 1, number 2. Notably, we initially dropped in the average performance as a region at the national level, but over time we are picking up and our districts are doing fairly well. We think we should be improving. That picture shows Rubanda district receiving a recognition just last year for being one of the best performing districts in the country. Because of those initiatives, we also managed to hold our maiden regional joint performance review mission for Kigezi. It was attended by more than 350 stakeholders, and we developed an aid memoir that was circulated. Some of you may have seen it, and I think the full report should also be getting into the circulation. Those are the pictorials. I want you to lower your eyes to the lower right-hand corner picture. That was our keynote address by Professor Tumwine, and he gave us how to eat healthy and not to have medicine for food. We have not stopped. We continue to have our quests for regionalization of our QI by going out to benchmark. We have visited many other places, and we have tried to borrow leaves from other places which are doing fairly well in some aspects so that we can improve what we have. We have been to Gulu and Elira, looking at how the regional parliament is performed and how it could help us improve. Bringing the various stakeholders in the regions to participate more closely in the governance and management of healthcare services in the region. We have also brought on board the university. We have Kabale University, and there is a faculty of medicine. Now that they have come to our hospital, we would like to work with them to improve patient care. And this will be best done if just 1 minute, if we know how to collaborate and coexist. Ladies and gentlemen, all I've said in those few minutes is that resource mobilization, coordination and identification of key stakeholders is crucial in ensuring functional regional QI and hence improving quality of healthcare outcome in our region. I want to thank you.
Big round of applause for Dr. Nyeko. Thank you so much. I beg that you can take your seat, but you'll keep the questions and comments. They'll be welcome at the end of all the presenters. Our second presenter is Wangubo Ayub. I don't know if the right pronunciation. Application of PDSA model to functionalize quality improvement coordination structures, the lessons from Kweni. Let's join him to welcome our presenter. You have 10 minutes, sir. Thank you.
Thank you very much, Chair. Good afternoon, ladies and gentlemen. My name is Dr. Wangubo Ayub, the District Health Officer, Kwen. And I'm here to present the application of PDSA model to functionalize quality improvement coordination structures. What we do best in Kwen to ensure that these structures are functional. IT. Okay, like I said, those are my names and those are my co-authors. Yeah, Kwen District is one of those districts found in Sebei sub-region in the eastern part of Uganda, and those are the bordering districts. We have 24 health facilities, 20 of them are government and 4 are PNFPs. 1 health center 4, 10 health center 3s, and 13 health center 2s. Kwen District is generally mountainous. It has 3 belts. We have the flatland, we have the middle belt, like a plateau, and then the highland. That is the geographical map showing the bordering districts. So, way back in 2015, MOH with partners set up guidelines on how to operationalize and functionalize those coordination structures at national, district, and health facility level. But since then, majority of these structures have remained non-functional. Of course, Kwen was not spared. So by 2022, we barely had a functional district QI team. But at least we had some few facilities that had some functional facility-based QI teams, courtesy of the implementing factors. So we set out to see how best we can improve or functionalize these structures, to functionalize the district QI team, and then functionalize the rest of the other facility-based QI structures. So I and my team, the DHTs, sat down, brainstormed to find out what exactly could be the root cause of the non-functionality of these structures. And we realized, or we found out that there were majorly 3 factors that was contributing to this non-functionality. One of them was knowledge gap and QI principle, the health facility teams, okay, the health workers, and then a majority of the leaders. We also barely had any kind of supervision for the QI initiatives in the various health facilities. Then, of course, we took QI as a partner thing. QI those are partner things, so we never prioritized it as one of the strategies through which we can improve quality of services. So what are the test changes that we employed to see that we functionalize these structures? Of course, the knowledge gap, we had to build capacity through our partners and then the regional QI team. Mbale regional QI team, it was vibrant and functional, so it did quite a lot to ensure that it supports us in building capacity. Then the supervision bit of it, we had to come up with the mechanisms of supervising and monitoring QI initiatives, both at the district and then the health facilities. So we had a team with clear terms of references to govern their activities when it comes to monitoring and evaluation. Then that mindset change of laissez-faire, you know, not caring about QI, we had to adopt this QI initiative as one of the performance indicators to the in-charges. Other than the other core roles, we also adopted QI initiatives as one of the assessment indicators at the end of every quarter. So these initiatives ran from July 2022 up to June 2023, and that is how the progress was. When we started in that last quarter, that's when we did the baseline of evaluating ourselves as far as QI is concerned. Like I said, we barely had a district QI team, so we didn't have it in place, but we had some few facilities that had. The first quarter of 2022, there was some increase. So there was a progressive increase, in other words. So if we draw attention to this line graph, when we did the orientation of the DHTs and health facility in charges and quality of care, that framework and the principles, we noticed some gradual slight changes, but it stagnated around quarter 2, October, December. Then Jan, March, we again had to employ another mechanism of fostering, because now we knew that these guys know what they are supposed to do. So we had to employ other mechanisms in which we can ensure that all the facilities have vibrant and functional quality. So we had to now bring on board the QI initiative as one of the performance indicators, and this helped us a lot to ensure that most of the facilities had a vibrant or functional teams. So what do we learn from that?
You have 2 minutes.
Improvement was attributed to compulsion of health facility in charges to prioritize QI as a regular monitoring and evaluation initiative. However, you realize that we did not score the 100% that we needed because of the other nitty-gritties, that the measures for you to qualify for a fully functional QI team has a number of parameters, some of which we were unable to attain due to logistics management. like having regular shared learning meetings, were unable to conduct those ones, so we could not hit their 100%, but nevertheless, we were able to drive it from 0 up to around 91%. So, conclusions, lessons learned, knowledge gap, negative attitudes towards use of CQI are major contributing factors for failed functionalities of health facility QI teams. And then funding QI activities, consolidating teamwork, and addressing negative mindset towards QI activities improved QI functionalities in Quen district. Thank you very much. Great thanks goes to our partners, Baylor, Ministry of Health, and the regional QI team. Thank you.
Big hand of applause for Ayub. Thank you so much. You actually used your time very well. And now take the honor to invite Ms. Prose Naluwege to make a presentation on improving proportion of facilities with functional QI committees in Mbale district. Prose, you're welcome. And you have 10 minutes. I will allot you at 8 minutes. Thank you.
Thank you so much, Chair. Ladies and gentlemen, protocol observed, good afternoon. My name is Naluge Prose. I'm a senior clinical officer. I work with Mbale district. I am also the district QI focal person for the district, but I as well support the region in quality improvement work. I'm here to share with you our progress towards the journey to improving functionality of QI in the different levels under Mbale district. It's entitled Improving Proportion of Facilities with Functional Quality Improvement Committees within Mbale district. I acknowledge the support of authors, but most importantly, the support given to us by our DHO, Dr. Wangisi Jonathan. The authors acknowledge that QI is a key aspect of service delivery and institutionalizing quality improvement approaches at the different levels of health service delivery. Ministry of Health, in its QI framework that we use as guide, that is 2021-2025, one of its aims is to improve leadership, management, accountability at all levels of healthcare delivery. Through our evaluation as DICO Mbale, we revealed that only 12%, that is a proportion of 2 out of 17 facilities under our support, had functional QI committees. And we had defined functionality as having at least one journal running, having a fully constituted QI committee, having at least an action plan in the recent past, having implemented 5S, at least to a tune of only the first 2, that is the SOT and the SET. That was our measure of functionality. A project then was instituted that aimed at improving functional QI committees in terms of proportion from a tune of 12% as of January 2023, I beg your pardon, to 100% in a time span of 8 months. What tool did we use? We used a commonly used QI tool that was a fish, the root causes to such a huge gap that we had in terms of functionalizing QI in our level 3s and level 4. When we used 5Y, we combined it together with, when we used the fishbone, we combined together with 5Ys to be able to understand exactly where the root causes were embedded. We noted with great concern that the DICO committee members themselves had issues of understanding and actually how to execute their different roles at the lower levels that they're supposed to supervise and mentor. We also noted that one of the other root causes, the facility leadership at the different levels of structure, had issues in understanding and also understanding how to integrate the QI work plan in their usual budgets. We also noted that 5 out of the 17 health facilities had QI teams that had no QI committees, and the 10 out of 17 had incomplete teams, and only 2 health facilities in a functional QI committee. We also noted that routine QI supervision were actually undetermined. There were imbalances in terms of adaptation and implementation of QI activities across facilities. We noted that some facilities would actually be implementing QI at almost all the parameters of our measures, but a bigger proportion had almost no parameter that they were actually fulfilling. What did we do differently? An orientation of the DICO was our very first step to take on their roles, and also taking them through the basics such that they can be able to understand basics of how to open up a journal, basics of how to support facilities to come up with problems that are actually affecting the different indicators of priority in our district. And our guide that we used then was the recent 2021-25 QI framework. This we do in each and every meeting that we hold every quarter to remind members, the DICO members, of their roles. We sent out letters of assignment that had been signed off by our cow district in Bale district. The facility in charges and their QI focal persons were then co-opted on the DICO committee. When we co-opted the DICO committee, when we co-opted the in charges and their QI focal persons of the facilities on the DICO, this took us a long way in holding them timely before their chairperson, that is the DHO, in terms of how much they have supported QI work in their facilities. And in all our quarterly meetings, the in charges and their QI focal persons come with their files as a form of accountability, and they are supposed to share what further they have done in terms of executing the QI activities in their facilities. But also additionally, this has had them being held in terms of integrating their budgets with a bit of QI work, but specifically having a token going towards the meetings that are supposed to be held monthly in their facilities. And also, in my district, no work plans are passed by my DHO to higher authorities without a component of QI being integrated in the budget. Later on, we formulated a facility QI teams as per structure, because this was also wanting facilities had incomplete teams that were not in alignment with the QI structure. Each clinical mentor that sits on our DICO committee was then given a responsibility of overseeing facilities as a way of having a bit of accountability when they come in our DICO meetings. They are supposed to do support on a monthly routine, courtesy of our implementing partners that at times offer us support in terms of vehicles and fuel and an SDA to those members that move out to facilities. A QI district WhatsApp group was also created, and this platform has given us a better way to discuss timely what has worked in the different facilities, share challenges, mobilize the members, and so many other things. In that run chart, what we see is a journey how we struggled right from January to our current status as of 2024. November, January was our baseline, wanted us to appreciate the problem that had actually been on for a long time. And from the 12% baseline of January 2023, we see ourselves sail progressively to a tune of about 88% in a span of about 6 to 8 months. And some of the things that worked tremendously well was allocation of a budget allocation, but also having our in charges being held responsible in the DICO meetings when they come to be part of the DICO members. Attachment of the QI coaches to specific facilities helps us keep track of the implementation work in the different facilities. In that picture, we see our chairperson, DHO, chairing one of our DICO meetings that seems to be, it looks very fresh. It was in our very recent meeting for December, October. What have we been able to see? With those changes being implemented, we've been able to note that 100% of facilities in our Mbale district are having fully constituted care committees. 100% of our sites are able to sit at least monthly because they have a budget allocation by the leadership at those levels. 100% at least have a journal being monitored in the indicators of priority nationally. And 100% are now able to allocate some funds for care activities like meetings at facilities. And also 80% of facilities are having evidence of 5S, this time up to a tune of SHINE, which is a good trend of progress. In our discussion, we note that quality improvement is an imperative undertaking essential for enhancing effectiveness and safety of health care delivery in all levels of care. Through assessment and targeted interventions and monitoring, facilities can be able to identify their own performance gaps, can be able to be supported to come up with innovations within their means that are evidence-based. What we learned from this sharing, that simple and low-cost initiative produce
2 minutes.
great results when leadership and coordination is addressed. In conclusion, co-opting in charges and their care focal persons onto DECO has improved accountability very timely on a quarterly basis. WhatsApp platforms is a very reliable, very cheap way of communicating and sharing learnings of quality improvement. In our recommendation, we recommend that quick adaptation and continuity of quality improvement is very paramount to involve leadership at all levels of service delivery at all facility care levels. I want to acknowledge support from our dear DHO, Dr. Wangis Jonathan, for having us sail through this journey of improving functionality, but also our implementing partners, Baylor and UHA. We are indeed indebted to you. Thank you so much for listening.
Thank you, Prose and Team Mbale. Jonathan, thank you for leading your team and giving them money. As I mentioned earlier on, we just need to keep our questions and comments. And now allow me to invite the fourth presenter, Madam Miss Betty Lajara, who is going to present on the implementation of real-time and periodic client feedback systems to improve facility responsiveness to client care concerns at St. Mary's Hospital, Acho. Betty, you're welcome.
Thank you. Yes, I'm called Betty Lajara, Principal Nursing Officer, Quality Assurance Focal Person, St. Mary's Hospital, Acho. Just like it's mentioned, we looked at implementation of real-time and periodic client feedback system to improve quality, facility improve responsiveness to client care concerns at the hospital. This initiative was fully supported by the leaders of Lacho Hospital and AFSI. Sorry for that. So Lacho Hospital is a referral hospital that serves about 250,000 patients annually. And on a daily basis in our outpatient, we see about 270 patients generally. And looking at this number of high turnover of patients, we notice that without quality improvement, we cannot serve our patients to their satisfaction. So this one brought us to think, because this huge number of patients, they always have their concerns that bring us around the hospital. So it gave us thoughts of how do we make sure they go out when they are satisfied. So we embarked on this real-time client feedback system that is aimed at gathering and filtering the message, the concerns that these patients bring for us, so that we improved on their services. And when we say real-time, we want to tackle it immediately as they come, and the periodic, which we focus on. So what did we do? We introduced this feedback system, which was set up at personalized outreach points. Initially we had only suggestion boxes around the hospital that we were opening it not quite often, but after like 6 months. But we thought that was not enough to take care of our clients. So we introduced emails. We opened our email free for people to communicate, phone calls, and then text messages. We also introduced social media, which focus on WhatsApp, Facebook, and Twitter. And this, additionally, at our outpatient points, we introduced client feedback books that whenever a client comes to the facility, they are actually encouraged, they are introduced at the beginning to comment and to write for us something that we need to change, something that we need to improve on, and then at the same time, if you have positive concerns, they are all written there. And this, I think I'm not, please. Yes, this system was enforced with introduction of constant communication office, which in previous years we didn't have. Now we have a fully functional communication office with a communication officer, and with our functional QI committee at hospital level and departmental level, we co-opted all the teams and we gather all this information, and they are discussed at outpatient on their daily review and in their monthly meetings. And then at the same time, we look at the suggestion boxes that we have. We review them every month in our QI committee meeting. So responsive actions were tailored to clients' concern, and then we summarize them. After our meetings, we actually send this to our management for intervention. So from July 2020 to June 2023, the implementation system yield actually tangible positive outcomes. It enhanced hospital image, and because in most cases we were receiving very many concerns from our clients right in the corridors of the hospital at the same time through social medias. So we got a lot of feedback, and very many people were giving us this feedback. We actually welcomed them positively. So the hospital social media following, particularly on Twitter, experienced a substantial growth of up to 78. And the client feedback include challenges, which are common things. Unless you listen to a client, unless you give them time to explain to you, you won't understand them, and they go back when they're not satisfied. Among them, we had prolonged waiting time, which is very obvious, and client computer system slow down, because in our outpatient we introduced the computer system in the pharmacy, in the outpatient, at the same time in the laboratory. So sometimes the systems can fail us. And then we had instances of staff rudeness, which actually was very common, and some drugs not available. There are some drugs that are not in the hospital formulary, and sometimes when we stock them, they take long, and patients were not happy. Why should we not have these drugs? But usually we direct them. So client feedback highlighted humane care and quality investigation and treatment available. So among these, we also noticed that most of these concerns comes as a result of failure to communicate well. If you don't communicate well to a client on where they are supposed to go, you cannot actually satisfy them. So with constant communication to these clients, we actually help them and they understood us really very well. Next slide. These are all feedback that we captured from our client. Next.
2 minutes.
So this project result highlights the profound impact of timely response of our clients, and it actually elevated both standards and overall experience of clients. As we continue to have this feedback, we notice a reduced dissatisfaction from our clients, and at the same time we had very good positive feedback from them up to now that we are talking. We acknowledge the realistic and well-intentioned nature of many patients' concerns, which we address, and the authors actually address the intrinsic overwhelming healthcare challenges. For us, the healthcare workers, they think if you listen to a client, you are being biased on them. And the majority of staff do not take getting clients' feedback as important. And they thought we are listening more to the client and neglecting them. And yet we feel if you listen to the client and you listen to the staff, we come up to a compromise, and it reduces bias to both parties. So the dedicated commitment of staff, because when we have this, we actually gave opportunity for our clients to mention names, which sometimes people may think is actually not ideal. In our hospital, we have uniforms that have staff name. So we encourage our clients to mention names, and these names actually help us to deal with individuals. So noting that a client will mention your name whenever there is an issue will really encourage you to do better than you can do. So it helps us to address critical issues that help to improve also on the outlook of the hospital and general quality of services. Next. So these results affirm purposeful management interventions to seek and respond to clients' concerns, not only attainable but yield commendable results. It also manifested improved client experience and constructive staff correctiveness, as I have explained. The results underscores informative influence of proactive measures on the hospital's image, and then advocating for an ongoing commitment to addressing clients' feedback. Next. So what did we learn from this? We are saying real-time responses to clients' concern emphasizes potential of this response in shaping an individual. It also shapes the impression of people on an institution. Summarize. Yes, 1 minute. And then now we look at correct actions culminating positive outcome for both the client and the patient. We are saying positive or negative, a feedback is very important. And client feedback can be used for quality improvement. And we always say, quality begins from you and me. If I don't embrace quality, if an individual doesn't embrace quality, we shall never achieve quality. So let me take this opportunity to say thank you.
Put our hands together to appreciate Betty.
Of AFC and then the management of Lacho Hospital. Thank you so much.
Thank you, Betty. Thank you, Lacho, Team Lacho. And we shall reserve our comments and questions. Allow me invite the second last presenter, and I've reduced their time to 8 minutes, and that is Lucia Nachigi. Lucia will be presenting to us improving client satisfaction for women screening for cervical cancer. Lucia, you're welcome. IT, please project.
Thank you, moderator. Very good afternoon to us all. Once again, I am Lucia Nachiega Wamala, and I work with Macquarie University Walter Reed Project as a Quality Improvement Technical Advisor. As earlier hinted, I'll be presenting on how to improve client satisfaction for cervical cancer screening, and this is majorly findings and feedback from what we did. So in July 2023, the New Vision wrote an article, and they were highlighting how women are coerced for cervical cancer screening services, and on the spot was Mukono General Hospital, which is one of the facilities that we get to support. And as an implementing partner that supports this hospital and several other hospitals and health facilities in Mukono district, in Mukono, Kayonga, Buvuma, Boyikwe, and currently we also have Luwera and Nakasongola, we set out to ascertain the level of satisfaction of women with the cervical cancer screening services. We also wanted to see and appreciate the quality of the cancer screening services and also determine the factors that are influencing cervical cancer screening satisfaction. And we needed feedback from the clients on the clients that are screened. We needed to get their experience, their perception of quality, willingness to recommend cancer screening to any other woman out there within 25 to 49 years, but most importantly, we were interested in their overall level of satisfaction. And the methods that we got to use, looking at the proportion ever screened, we focused majorly on Mukono General Hospital, as earlier highlighted. This hospital has had a total of 3,448 women by July 2023. And of these, we had 2,437 had been screened for cervical cancer, and that gives us a proportion of about 71% of the women had been screened. And we definitely sat back and realized that we would be having a few limitations to this survey, and some of these were regarding sample size consideration, given that we needed to really ascertain the satisfaction, but within a short period of time, with limited resources. We only reached out to 50 women, which is only 2% of the women that were ever screened. But to allay our fears, we'll be able to see that at least the confidence level we arrived at was quite good to give a good representation of the findings we're going to share. And also, the other limitation is around recall bias on the service quality and experiences, especially for women that had been screened months ago. Sample size estimation, we use the RMN's formula for sample size estimation. And as we get to see, our confidence level was 90%. And this is majorly in summary to say that at least for the sample that we got, we would, 90%, it would have a good representation of about 90% of the women that had ever been screened. And putting the proportion that we had, the sample, into our formula, we were meant to reach out and interview 56 women. We used the purposive sampling method from women that were awaiting refills at the facility for about 3 to 4 different clinic days. And we had a very good response rate of 100%. And we administered a client satisfaction survey that was translated in the local language, and majority of the clients speak Luganda. So this was translated to Luganda, and we were able to interview a total of 50 women. Our first bit of the results, we were able to see some of the clients that responded yes to the different service domains. And I'll first focus on the domains that had over 80%. What really stood out was privacy and dignity respected. We see that 98% of the clients that we got to interact with appreciated that their dignity was respected. They encountered privacy while being screened for cervical cancer. And we also got to appreciate that a good percentage, 84%, were aware of cervical cancer screening services. And then we see 83% of the women, especially those that had been Those that needed treatment or those that needed thermocoagulation had received follow-up. And then we see some of the other areas that were fairly, women responded yes, but it was at least below 70%. We see that about 60% of the women that had been screened responded that they were able to receive a bit of counseling and education. And then about 72% were involved in decision-making, which we found fairly okay. But very key for us is where we see the red score of only 38% of the women said that they had seen IEC materials, which leaves us with the other balance of about 62%, wondering why they were not able to look at any visuals concerning cervical cancer screening. So we go to the right, where we see clients' perception of healthcare worker service delivery and the screening environment. The first three bars are majorly looking at the healthcare worker service delivery, and then the last one is looking at screening environment. And we majorly did poorly here regarding health workers, the ability to bring clarity on why the patient is getting screened. We saw that about 44% ranked poor for this particular domain. We had rankings from excellent, very good, good, fair, and poor. And particularly in regards to being able to give clear information, about 44% did not get this information. However, all the other domains, looking at quality of care, we had over 80% acknowledging it was good, excellent. And then when we come to friendliness of the health workers and empathy, we had also over 80%. We see 17% were excellent, 27% very good, 44% good, and only about 12% said it was just fair. Empathy was only fair. And then where we did best was regarding cleanliness and majorly cleanliness of the examination room and how convenient it was. We see that the key feedback and ranking was majorly from good ranking upwards to excellent. And going on to the other results, we're able to see how likely were the patients able to recommend cervical cancer screening, those that had been screened before. Overall, we see that 98% of the women living with HIV between 25 to 49 years were willing and ready and open to recommend cervical cancer screening to their counterparts, and only 2% were neutral. And when we get to look at overall satisfaction with the cancer screening services that were received, we see that close to 90% of the women were either satisfied or very satisfied, with 16% very satisfied and 74% just satisfied. And we have a 2% that were not sure, and we have the other, about 8%, that were not satisfied. That's 8%. And going on to, I just want us to see those that were not satisfied or those that would probably not recommend cancer screening services. What were some of the issues? Maybe just to take us back to the very first slide, what triggered us was the feedback from New Vision. Just to take us back to the first slide, and we really needed to find out the feedback from the clients that we're working on. So we have 5 clients that were not satisfied, and we're able to see the different reasons. I may not read all in the interest of time, but just to pick out 2 of them, some of them, one of them was not satisfied because they were not given screening results. Another was not satisfied because they feel they needed more health education regarding screening and or preventive measures. And then looking at the overall recommendation, at least from all the clients that had been screened, they span from maintaining all that is being done and then being able to provide more health information, quite a number of recommendations. And I just want to take us back to this particular slide that I had skipped. And this is majorly focusing on some of the, when we did the analysis, just to see the associations, what are some of those things that will trigger satisfaction Is it age? Is it level of education? Is it marital status? And we were able to see, because we had a number of variables that we got to compare with level of satisfaction, we used a Pearson chi-square test, and we saw that only 3 variables were significant with a level of satisfaction, and that was age. It had a positive correlation. So older women were more satisfied with the cervical cancer screening services. And then we also saw that quality of care received. We left quality of care open to the judgment of the client. And then the lastly was on willingness and ability to recommend. And finally, to conclude this, as we conclude key recommendations, we see that it is very important for us to empower the older women, especially as champions for cervical cancer screening, to inspire and encourage the younger women, since we saw a very good positive association. And then it's also key and important for us to increase awareness for cervical cancer, for HPV vaccination, awareness and availability at our health facilities, especially at health center falls and above. And then it's also very key to improve referral pathways, especially for women that get to have abnormal screening results, since we saw this as some of the recommendation on improving the quality of care. But I know this is not only unique for General Hospital. And it's also key, as we saw that the quality of care had a positive association with a level of satisfaction. It's very key and important for us to sustain the quality of care, because it gets to meet the needs of our clients, and not to say, given that it's one of the key principles of quality improvement. Thank you so much. That is
a big round of applause for Lucia, and we appreciate you and your entire team, Morap, for this great work. Our last presenter is Jeanette Amito. Jeanette will be presenting to us. We can clap for her. Jeanette will be presenting to us quality improvement initiatives to improve participation of clinicians in functionalization of QI structures and implementation of QI initiatives in Lamour. Jeanette, you're welcome.
Good afternoon. My name is Janet Amito. I work in Lamour District Local Government. Lamour is one of the districts in northern Uganda and the Gulu region. I'm an assistant nursing officer. As our topic of today, I'm presenting improving participation of clinicians in functionalization of QI committees and implementation of QI initiatives at Lamour District Local Government. As we are all aware, today everyone was talking about innovations, improving participations of our health workers, clinicians. So as a district, we innovated in a way that everybody who works at the healthcare participates in quality improvement. Because if not everybody is on board, we shall not achieve what the Ministry of Health and the district needs. So as we can see, as a district, the Ministry of Health recommends that at least at Health Center 4 and Health Center 3 level, there should be 100% of functional quality improvement programs. And as a district, we identified there were some gaps. That's why we came up with this innovation to improve the functionalization of participation in Lamour. So one of our key gaps that we identified was knowledge gaps by the clinicians on quality improvement initiatives. There are a number of areas that as a clinician, as a healthcare worker, you need to know in order for you to improve and participate in quality improvement. There was also lack of internal and external support supervision. Here, as we heard in the morning, in order for us to improve on the quality improvement initiatives, there should be supervision happening in the facilities, both internally and externally. We also identified that there was poor system in place to reward and sanction the best and poor performing clinicians. In this way, as it was spoken by one of the presenters, if everybody knows their roles, and if I know that if I do well, I will be rewarded. If I don't do well, I will be sanctioned. In this way, the system will improve, and quality improvement initiatives will also be implemented by the different groups who are working at the health facility. What did we do as a district? As a district, we conducted health facility quality improvement baseline orientation on key areas targeting all clinicians. I know some of us are wondering, who are these clinicians? Because at facility level, nurses, we have midwives, we have clinic officers, we have medical officers. All these ones are involved. We are not meaning only the doctors or the clinic officers. Nurses and midwives are also clinicians, because if the medical officers are not around, they take over that system at facilities. So everybody has been oriented on the key areas. Secondly, we also conducted the quarterly clinician-led inter-facility learning sessions to improve on the knowledge of some of the clinicians who didn't know what were those quality improvement initiatives. We also had a baseline assessment on 5S. As we heard, 5S is a key to quality improvement implementation. And we introduced the baseline 5S to the clinicians. We were also giving feedback on quality improvement functionality and 5S implementation progress. Because for somebody to know that they are working or they're involved, you need to give them the results. As we took them through, we gave them the baseline orientation, conducted the clinician-led facility learning sessions. We are supposed to also give them feedback on how they are doing or improving on the quality improvement initiative and also 5S progress. We have also integrated quality improvement into the routine support supervision because we know that as a district we conduct monthly, quarterly support supervision in all health facilities, especially Center 3s and 4s. So we, as a district, we made it a point that quality improvement needs to be integrated into the routine. Whatever you go to implement, to see at the facilities, you need to put quality improvement. You need to look at the 5S, as we heard the minister talked in the morning, that she almost entered under the table to see where 5S is. So if you don't improve or integrate the 5S, if you go to facility, you don't look at the projects that they are implementing, you will not know whether the quality improvement initiatives are being implemented at those levels. So these are the results that we have seen from April of 2022. That's the time that we started implementing this activity. As a district, we were only at 23% of clinicians participating in the quality improvement initiatives. After introducing those changes, as a district, we have been able to move, as we can see, from 23% in April of 2022 to 2023 April, we have been at 76%. And currently, the facilities and the district are still implementing those initiatives that were introduced to them to improve and make quality improvement part of them, so that we don't withdraw. As the partner also withdraws, the district staff also withdraw. For the district, we are continuing and we are still doing the needful. Next. As a lesson that the district has learned, we have seen that if we engaged all the district structures, we create awareness through meetings, through learning sessions, and integrated support supervision. Those areas are critical for us to improve and also interest the participation of the clinicians in quality improvement initiatives. And in conclusion, quality improvement initiatives and programs can be improved when all the clinicians are involved, coupled with skills and knowledge that you empower or you give to the various clinicians. If everybody has the information and the knowledge, they will be able to improve on the quality improvement and the quality of service that they offer to each and every client and patient that come to the health facility. Thank you.
A big round of applause for Janet. And Janet, just remain seated in front there. I don't know if you'll make it.
Okay.
Is that comfortable for you?
Okay.
I'm kindly requesting that we get very quickly all the presenters and one question each. That will be enough appetizer for your lunch. Dr. Philbert Nyeko, guide your team. Step forward. You have enough seats in front. Lucia. And now I'm moving the mic for 6 questions. 6 hands. The questions might be slightly more, but 6 hands. But I want to limit 1 question per person. At most a comment and a question. If you had 2 questions, turn 1 into a comment. Yes. Here, 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, times 2. Can someone move the mic? Number 1 is here, around here. It's only 1 microphone.
Good afternoon. My question goes to Betty. I would like to know the trick they used to reduce computer breakdowns or shutdowns or slowdowns, because we are facing that challenge. Thank you so much.
Thank you so much for enriching me, all the presenters. Thank you so much. I have only 2 concerns. One is about quantifying. Whereas this concern is for all the presenters, I would wish the presenter Ayub from Quen to represent all the presenters. I want to cite an example of supervision. When you said there was inadequate supervision, did you mean there was inadequate in terms of frequency or in terms of the content? When you say inadequate, what do you mean? Just help me on that. Then the other thing related to that is that you did interventions. Of those interventions, is it easy to cite out which ones worked and maybe to what extent they worked? So that's about quantifying that I want clarification. The other one specifically goes to Lucia. When I read the title, it was about improving satisfaction. So following the conversation, the presentation, it appeared more of an assessment. Did I get it right, or it was more of finding out the levels of satisfaction How do I connect it to the title? Thank you very much.
Thank you. Thank you very much, Session Chair. My name is Moses.
Oh, we can't hear you.
Oh, the microphone is not functional.
Second microphone.
Thank you very much, Session Chair. My name is Moses Balina. I am a public health specialist working with Maldima Uganda. And my question goes to Dr. Nyeko. Thank you very much for the great work in the region. Now, the Director, Regional Referral Hospital, being a healthcare worker, possibly understands quality improvement more than a Chief Administrative Officer. Now, it comes that the cow is the person who appraises the DHO, who is the chairperson of the DICO. What has been the role of the Chief Administrative Officers in functionalizing the DICOs in your region? Thank you very much.
Thank you very much. My name is Peter Okelo-Deke from Lira. Just cutting across. One, there is usually this challenge where people who have worked in a facility for a long time, when you come with some innovations, you begin saying you came, got us here, and you leave us here. But I think call it basangwa, something like that. Somebody knows better the right word. What has been the key challenge we have all met as presenters in this area, done innovations, relating to those kind of staff who have that attitude towards the innovations? Two, if allowed, is also that, especially for Mukono, there is usually this urban-rural setting, and the competition. I'm trying to bring the issue of having the private clinics against the established facilities. Now, when you're looking at client satisfaction, did you try to interrogate what comes from the clinics as compared to the public institutions, given that there is always that thinking that government or public institutions, the services are generally not what? Okay, thank you.
Thank you. Thank you. I'm Sandra. My question goes to Betty regarding client feedback. How did you ensure client privacy and non-disclosure of this, of these clients? For example, how did you ensure that the clients were protected from staff exploitation? If they give you their information, how do you protect them from exploitation from staff? And when this health worker knows that this client gave a bad report on me, how do you ensure that the clients are protected? Thank you.
Thank you very much, all the presenters. I'm Stephen Chigongo from PMI Uganda Malaria Reduction Activity. My question goes to Betty Lajala. I wanted to ask what percentage of the issues from routine feedback was actually most prevalent? And what percentage were we able to address comfortably during this real-time feedback? Did you notice any decline as we moved along the course of time? Because we would have loved to see such visuals in your presentation, which we missed out. Thank you very much.
Thank you. Good afternoon. Thank you to all the presenters. My name is Salma, QI officer from IDI. This goes to you, Betty. I think you've gotten quite a number of questions, but I'll ask it anyway. I realized that in your results section, you did not give us exactly the quantities. I think that's been going around from everyone. But it would be important for us who want to go and, apply these principles in our respective contexts to know what are the characteristics of the people that, you got responses from. What are their literacy levels, the characteristics, their age, because many of the facilities out there state that they do not do client feedback because, they're using suggestion boxes. The clients can't write their literacy levels. And you mentioned positive outcomes. It would be very, very important for us to quantify that. You mentioned it's many people who responded. It would be good for us to know how many people responded per, mode of communication that you used. Thank you very much.
There are two hands in front here. One of our...
Thank you so much. My name is Rebecca Nachimuli from Kira Municipal Council. I really appreciate the first three presenters. Actually, I came to learn lessons in functionality of QI committees. My question goes to Queenie. I wanted more clarification on what was the numerator and denominator in the assessment of the DICO when we are talking about one district, which is Queenie. Unlike with Dr. Nyeko, where we had 6 districts, for the presenter in Queenie was addressing one district, but was rating it the same way the 6 were rated. I wanted to know how was that one district assessed. Thank you.
Yeah, thank you very much. This is Amoding Salme. I come from Moroto district. I had also a concern to Sister Betty from Lacho. For a scenario of Moroto, when we do client satisfaction, there are those ones who are not learned, there are those ones who don't know how to read, and according to the scenario of Lacho, the client satisfaction, you are using WhatsApp, you are using Twitter, you are using what? So for us in Moroto, we don't have those who know how to read and write, and on top of that, they don't have phones. So how have you taken care of those? Then the other question goes to DHO. When I was like, that graph was staggering, like it was flowing at the same levels. And in that, in my mind, I asked, could it be because you introduced so many tested changes at the same time, and that's why the graph was just moving at the same phase? It was not really yielding fruits where you could see that at least this one change I've introduced that has worked out. So I also needed some clarifications on that. Thank you so much.
Hi, yes, my name is Jessica Healy from USAID. This is an open question, and I understand this panel was on leadership and governance and systems and customer satisfaction. I was just curious if any of you had major health outcome results that, that you really identified through these, but maybe didn't have a chance to present, that you could share with us, or any kind of significant systems improvement that came out of the improved governance or feedback. But thank you very much for all the great presentations.
Thank you. I'm called Esther Nkolo with USAID. My question is to the district representative, but I think I'll direct it to Janet of Lamour. I'm interested in the district processes for prioritizing QI improvement aims. What do you go through to decide, and how do you manage the influx of priorities from national level? You get priorities from TB, maternal, newborn, HIV, and so on. As a district, how do you support the facilities and communities to choose what they can manage in a specific period? Thank you.
Chair.
Chair, a quick one.
Oh, yes.
Thank you very much. I want to appreciate all the presenters. Martin Senluna from the Ministry of Health. Client satisfaction is everybody is becoming increasingly interested. And what I wanted to really emphasize that we need to institutionalize this, to have it being done more frequently and routinely, and then address the issues as the presenters have done so. My quick question is if they are incurring any challenges on the cost or they have a small budget for it, they may wish to share with us and we know the implication of that. Then the second one is maybe an advice. I think we may not need to mention names when we are implementing client satisfaction, as it was mentioned by one of the presenters, because this is done in good faith and good purpose to improve quality of care. When you start, mentioning names, people will feel victimized, and it may affect the good purpose of the client satisfaction. Thank you.
Yes, I can say hand just behind Dr. Martin.
Yes.
And that should be the last.
Okay. I'm Stephen from the School of Public Health, Makerere. I have a question for Lucia concerning how she measured client satisfaction for women screened for cervical cancer. She had domains in the event of just satisfied, very satisfied. Was there a description of these domains for the clients to be able to respond correctly?
Thank you, and because of time we've got to put the questions at that level, but allow me before I call them to respond to highlight something that's very cross-cutting. One, in leadership there's a lot of accountability, and some of the quality issues we are buffering with at service delivery level are because of indiscipline and absenteeism, and you may not get quality where there is absenteeism in discipline. And this didn't come out. The component of leadership emphasizing accountability for results. I think across the board, that's just a comment. Then the second comment from me is I didn't see QI as being proactive. Proactive in the sense that even before the problem, if there is a problem, there is a system, because as Martin has mentioned, this needs to be institutionalized. This is not the first framework. We are probably implementing the third QI framework, national QI framework, but we want to see that you were somewhere, and that makes it sustainable. DHO Quen, where did the other framework leave you? Did it now, after this, if this is an amplified effort, is it also going to collapse? What is put in place to make sure that these systems are sustainable? So I think with those remarks, allow me begin with, again, the elder, Dr. Nyeko, and the order, the way you presented, not the way you are seated. Dr. Nyeko will be followed by Ayub.
Thank you very much, Chair, and thank you, members, for those questions. I think they are very exciting. I had prayed earlier,
yeah, sure.
I had prayed earlier that the chairman loses his watch so that we discuss a little longer, but I think that may not be possible. Let me begin with a general comment from Mr. Deke. The issue of I know it all. You found us here, you leave us here. I think that is a very serious concern that we should all open up our eyes at. Such group of people do exist, and they actually make work very difficult for those who are doing work in progress, work of implementing QI. We need to find a modality of helping such people also rotate. Maybe if they see how Lira does it differently, how maybe Fort Porto does it differently, they will be able to change their mind and appreciate the dynamics in service deliveries, that there is no one person who knows it all, who can do it all. They also will appreciate that the healthcare is not static, it's dynamic. Things keep changing day by day, and that will help us to also change with the changing system. So my appeal is to the Minister of Health that yes, we need to look into that. There was a proposal of recentralizing some cadres in health. I hope this is a work in progress, but we also need to implement the frequent rotation of health workers. There was a question specifically from Michael to me on the CAO appraises the DHO. How do we involve CAO in functionalizing the DICO? True, the CAO is the immediate supervisor of the DHO. The discussion around that, I'll not go into it because there is a technical component and then there is a managerial administrative component that the CAO has to deal with. The other medical component can be very difficult for him or her to supervise. This is where we would come in to help. The relation is not directly proportional, it's a bit indirect, and so we come in. How does the CAO help us? The chief administrative officer is the accounting officer of the district. So all resources, including the human resource in there, is under his control. So for us to succeed, we must bring the chief administrative officer on board, appreciate the little that we intend to do, and support us morally and many times financially. In one of the presentations, the district is not allowing a budget for a certain facility to come on board unless they have component for QI.
Dr. Nyeko, we've got summarized.
Yes, and that is an indication that the CAO has control and we need to bring them on board. Where they say yes, we're likely to succeed. Thank you.
Thank you, Dr. Nyeko. The rest of us, 2 minutes strictly. Ayub?
Thank you very much, Chair, and appreciation to the colleagues who have raised those concerns. I had quite a number of questions raised. The first one was asking, sorry, I didn't get the details of the persons asking.
No, go ahead if you got the questions.
So the first one was asking, how did we quantify the parameter? Okay, the denominator versus the numerators, and you find that okay, when we were implementing this, it was more of a qualitative assessment. That we look at the functionality of DICO. We had 10 parameters that would qualify a district QI team functional, among which we had things to do with the do you have members appointed, official appointed by the accounting officer? Do you have regular meetings? Do you have a QI framework? Do you have projects that you're implementing, including 5As, and then reporting to the relevant stakeholders? So the regional QI team was grading us on those parameters, and I remember there were 10 in numbers. So as we started, we had nothing. We didn't have any member appointed by the accounting officer. We were not sitting regularly. We didn't have any QI project. So it was zero. As we went along, we started putting in place those key parameters that would qualify a team functional. So that is how we graded the district QI team. The same was applied to the health facilities, but now we changed to, if a health facility has all those parameters, they have the QI team, they are sitting regularly, they have the projects implementing, we take it as a unit. Then the denominator would be the total number of facilities that we had in the district. This one answers question 4 that also came from one of the other people. There's another question that came as to why the graph was staggering. Did we implement all the test changes at the same time? The answer is no. We first started with capacity building. It brought us to some level. Then when it started staggering, we employed compulsion, adopting QI as one of the performance indicators for in-charges that would be assessed at the end of every quarter. So that one pushed us to another level. The second last was, I think this one was a general one, asking what worked best for all the projects that the various presenters have presented. You find that in Quen, what worked best was introduction of QI initiative as one of the performance indicators for in-charges. That one, it worked for us. And then my colleague from Mbale, they had money allocated, resources allocated to QI. It worked for them. Then there's another colleague who mentioned that rewarding best performers helped them to improve functionality of their QI structure. So you find that whereas we had one common goal of functionalizing these QI structures, we had different approaches, and those are some of the approaches that I managed to capture. Then from the chair, he asked, where did we start from and where did the other frameworks leave us? I want to mention that when I was presenting, I clearly indicated that at the district we were at 0. That one I admit. But we had something going on in the facility, courtesy of our implementing partners, majorly HIV and TB. Baylor had some facilities that it was supporting, which had at least some functional QI teams, and there was some semblance of quality improvement there. So that was our starting baseline. Thank you very much.
Thank you, Ayub. Proce, 2 minutes, please, if you can stick to that.
Thank you
Otherwise,
so much.
lunch is...
Thank you so much, Chair. I actually did not have a question addressed to me as a presenter, but there were 2 questions that were addressed to us in general. I want to respond to 2 of them. One was saying that staff that who claim have been on ground for a while, and so they are there to stay. How do we handle such case scenarios? I want to use the experience of Mbale district, whereby we have rewards and sanction committees at every levels, including the district level. We handle such members at facility level, and in case we've failed to handle fully, we can push them forward to the district level, which holds theirs every other month, but sometimes bi-monthly. But also, there is something that we are trying to test. We are calling it a counseling book, whereby in charges, as a way of human resource management, they keep engaging individuals that are having challenges of having results at their facilities. Then the other question that was raised was health outcome results. Health outcome results was a very difficult to measure for most of the indicators that are being tracked, since we had struggling structures at all levels. Now we started by streamlining quality improvement structures at all levels, including the work improvement teams that now are very equipped on what to do. So as Mbale district, in every quarterly performance review that we hold, we filter out struggling indicators, tag them to the focal program persons, TB, HIV, then they prioritize 2 indicators to open projects at district level for tracking. Then the innovations we have agreed on at a district performance review, we support facilities to still go down to their individual facilities, open up similar projects that are feeding to the district project, and in such a manner we are able to track performance in the indicators that are actually struggling in our district. That's what I'm able to share from Mbale district.
Thank you, Proce. Betty, 2 minutes.
Yes, 2 minutes, but I have a lot. Let me try.
Most of them are cross-cutting.
So the first one was about computer breakdown. How did we solve the problem? We set up a routine maintenance for this computer breakdown, and most of it was due to network problem, and it was slow network. Some computers were actually out of use, so the hospital managed to procure some new computers which were fast enough. For the slow network, we managed to set up many service points. This one also served for the long waiting time. There was concern about percentage, which concerns were very common. The common concerns of our patients was long waiting time. Long waiting time, which was attributed to the computer issues, and then few clinicians. But we were blessed that we employed more clinicians at these outpatients, and then the service areas were increased. Privacy for the clients during feedback. This one also comes together with issues of tagging names. Actually, in the beginning, we were not tagging names, and to the staff it was okay. When you come and you say, "You are rude," and then no one will think they are talking about them, and the rudeness continues. And at the same time, the ones who are not rude will not be happy. They will say, why are you generalizing? So it's a double-edged sword, because I'm not rude and you're saying all the staff are rude. So actually in our committee meeting, everyone agreed that instead of generalizing, why can't we ask these clients to mention names? And even despite of asking them to mention names, some of them were actually bold enough to say so and so, because some of these personalities were continuous, they were continuous. So by the fact that we tag names, for us as the Cho Hospital, we felt it was okay, because transparency is actually paramount. And if I know they will pin me out, next time I'll actually change. And then there was an issue of, the privacy part. We don't disclose, we don't ask these patients to tell us their names. And usually we have independent people who come to carry out this survey. Then there was issues, people who are not able to read and write. We have various modes of carrying out the surveys. Like I say, the on-site book is for those ones who can read and write. And then we have monthly surveys where someone comes and interact with these patients. We know most of our patients are actually unable to write. Majority of our patients, they come from hard to reach and they are not able to write. And then we have also quarterly survey that we do, and this one also caters for those ones who are not able to read and write. So there, everyone is actually catered for. There was an issue about cost of satisfaction surveys. For us, our satisfaction survey, we have not attached any cost to. Actually, when you tag cost to satisfaction survey, we tried and it was never successful.
I want you to
people
conclude.
come to do because they think there is money, but we deal with people who don't come to ask for money.
The rest they will ask you at the lunch break. Can I move to Lucia?
Thank you.
2 minutes. Lucia, 2 minutes. Then
Thank
Janet,
you.
2 minutes.
Thank you, moderator. I think I had about 3 to 4 questions. The very first question, how does the gentleman who asked connect the presentation to the title? He saw the title had improving client satisfaction, and then the title, and then the presentation had findings. Majorly looking at if we had followed through, coming from the objectives of this particular presentation down to the recommendations, we're giving a highlight of key determinants of client satisfaction. And maybe just to highlight at the end, for some of the recommendations, I just want to reiterate, and probably for the rest of the recommendations, we'll have a detailed interaction. Some of the key determinants, and we also noticed key associations or correlations with client satisfaction, was making use of older women to inspire and encourage younger women is a very key determinant to improving client satisfaction. And then increasing awareness and availability of HPV vaccination gets to, and also health education on early cervical cancer screening, which was among the recommendations. Improving referral pathways for the different women with abnormal screening results, and also sustaining quality of care. That was from the recommendations, and it directly speaks to the title and from the findings that we had. Then the second question was majorly focusing on, were we able to interrogate clients from private clinics versus public facilities? No, we did not. Given that our sample size was majorly narrowed down to women living with HIV and have ever been screened for cervical cancer in the different facilities that we support. But this is key feedback, especially for consideration, given that we want to improve health care and access at all different levels and of care. The other was their description of the domains for clients to ascertain satisfaction. So yes, we had a thorough and detailed description, and the domains did not finally give a score of satisfaction. There was a separate question that was basically asking to what extent were you satisfied with the cervical cancer screening service. However, this was translated in Luganda. So the client would respond very satisfied, highly satisfied, etc. So that is the question that scored satisfaction with different rankings. The domains that we saw are the ones that kind of led a client to their final score, and also bringing to mind what their experience was like. We see that a client that responded, they were not satisfied, and one of the recommendation was not to tag refills to cervical cancer screening. Definitely at the end, also they were not satisfied, they would not recommend this, and some of what came to mind, or the reason they were not satisfied, is because these were tagged. So we had different questions that were finally leading to a final score, and some of them, as we got to see there, privacy, if a client didn't feel like the screening process was quite confidential, was the health worker empathetic, really questions around awareness, availability, health worker attitude, the environment. All these finally were leading to the last question and how they respond to it, on how they were satisfied with the service. Thank you.
Thank you. And our last respondent, Janet, and I think you have only one. Over to Janet.
Thank you so much. As a district of Lamour, there was formation of working groups, work improvement groups, which was formed at the district. So there are a number of areas that these groups were supposed to oversee: maternal, child health, we had TB, HIV, and quality improvement itself. So people were given responsibilities in small numbers, like 4, 5 in a group, to see that there is improvement in these areas. So as a district, why we came up with this innovation of improving participation of clinicians, were because much as we have maternal, newborn, child, TB, HIV being implemented, that part of participation of clinicians in these areas was very low. That's why the district came up with this innovation, so that if we want to improve maternal child health, we want to improve TB, HIV, the quality improvement itself, the functionality and the participation has to first be improved. That is why we came up with this innovation, and as a district we chose this so that we improve on these other working areas like maternal, newborn, TB, HIV, and other functional areas at the health facility. I would also like to add on the questions which was asked about those staff who are not interested in performing quality improvement services. That for that staff in a district, like in my district, you give that staff an activity. You give a project for that staff to head so that they know and take initiative that if I don't implement or I don't make this project improve, I will be sanctioned or I will be punished. So we involve everybody, especially those ones who have the negative attitude that the change you are bringing is not going to maybe bring improvement. We involve them in those activities. We give them projects so that they learn and see that, oh, where I was going was not right. Let me move with the fellow colleagues and we improve on the quality improvement of the district and at facility level. Thank you.
Thank you so much, our dear participants. Let's put our hands together and thank this amazing team. You are now free to leave and have your lunch next to a piece of chicken for you and myself. For the rest of us, thank you so much for your comments. Thank you so much for your active participation. Is that hand for praying for us? There is no more hands. You look for the individual people and ask them questions. The meeting is officially resolved, and go for lunch because we are slightly behind schedule. The first group is already having lunch. Thank you so much, and have a blessed afternoon.
Yeah, let's give another round of applause to our session chair, Dr. Richard Mugahi, and also the panelists. Now, the arrangements for lunch, I know you already have the visas, the coupons for lunch. We have 2 restaurants here. There's Victoria Restaurant, which is just next from this side, and then there's also the resident bar. Don't worry about the word bar. So, because Musajja wa Kabaka can go to that one instead, but they're just serving lunch in the resident bar and the Victoria Restaurant. And after lunch, we shall be coming back here for the poster presentations for around 20 minutes, and then we shall go back to the breakaway sessions. So please, after lunch, let's convene. Just start off the poster presenters. Make sure you have an early lunch and you stand by your poster so that when delegates come, you are able to show them and explain what it's all about. Thank you, bon appetit, and see you at 3:45. Thank you. Just to alert the delegates, what we know, this place is very secure. However, it's also your responsibility to take care of your valuables. So please, if you have hard cash, which you fail to keep, I can keep it for you. But please make sure that you also mind about your valuables, however much that the place is secure and everybody here is trustworthy. But mind about your valuables. Thank you.
Good afternoon. Can we have the poster presenters? Please make sure that you're standing by your posters so that we can use this chance to have a poster presentation. So colleagues, those of you who are back from the lunch break, kindly use this time to have a look at the work that is being showcased in the posters. We give it a few minutes before we resume our breakout sessions. So we call upon all those showcasing posters, please come to the hall and stand next to the poster so that you can be able to take people through the work that you're showcasing. So we invite you all to the poster session. Feel free to move to the poster of your choice, as well as ask as many questions as you may want. And we shall continue this later on after the breakout sessions. So people presenting posters, kindly come to the hall and guide the guests through the presentations.
Hello, good afternoon, good evening. Dear delegates, can I have your attention, please? According to the time check, we have come to the end of the poster presentations, and we need to go to the breakaway sessions so that we can start. May I call upon the session chairs and presenters to go to the respective halls. Here we are going to have Dr. Ronnie, who is going to chair the afternoon session. Dr. Ronnie Bahatungire, I hope you are around. We remain in Ziba, and then Dr. John Paul Bagala is going to Kama. So after the breakaway sessions, when we come back for tea, the poster presentation can continue because it's a marketplace. So the vendors, those are the presenters, can always come back at tea time so that we can continue meeting more and more delegates coming to understand the work they have been doing. So can we move? Conference Chair Dr. Agre, I need some assistance. I need to know the session chairs, whether they are around, so that I can hand over and we start. Dr. Alex, in the meantime, as I wait for the session chair, may I call upon the presenters in this hall, that is Ziba Hall. Mugenyi Geoffrey, at least by show of hands, please can you come and sit on this? Can I have John Paul Kakonyero? Where are you by show of hands? Please, can you come over? Michael Nanjubu. Michael Nanjubu. Where are you? Then May Namukwaya. May. And then Babile Lillian. Babili Lillian. Babili Lillian, may you please come forward? The poster presenters, Dr. Julius, just help me to tell the poster presenters we have ended the session now. They can resume at tea time. And the delegates who are going to stay here, please stay here for these presentations according to the program. In case you are interested in the presentation in Kama Hall, please proceed to Kama Hall. So you only to Secretariat, can you please contact Babili Lillian just to find out where she is? Yeah, I want to announce the session chair for Ziba Hall is going to be Dr. Wangisi, the District Health Officer from Bale District. Dr. Wangisi, please come forward so that I hand over to you to proceed with this session. And in the meantime, those of you who are part of this breakaway session, can you please take up your seats? And in case you are still looking at the other posters, please do it quietly so that we can have the required silence for people in this breakaway session to be able to follow what is happening. Secretariat, can you please follow up with Babide Lillian? If at all she came and she's still maybe having lunch or somewhere, please try to raise her on phone so that she can come over. Thank you. So this is the last call. Morongo Babidi is here. So all the panelists for, and may I request just by in any case if presenters for Kama Hall are still stranded here, like Sarah Zarwango, Tino Mujini Muzafaru, Stephen Apol, Nagudi Frida, and Ivan Segawa. If you are still looking at the posters here, please, you are in the wrong place at this moment in time. Please proceed to Kama Hall where you are going to make your oral presentation. And now the session in Kama Hall is about to begin. Please, 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 let's observe what we have said. The poster presenters, please stop. I'm just requesting you humbly. We have ended. Dr. Martin, you can help me out, members, to end. The poster presentation will resume at evening tea. They will resume at evening tea. So the poster presenters, make sure that you come and you meet any of the other delegates who may still want to look at your posters. Remember, you are presenting for only one day, so we expect you to come back again to complete. So those of you who are going to participate in this breakaway session as per program, because each one of you has a program, please get seated. In case you are interested in the the oral presentation in Kama Hall, please proceed to Kama Hall. So good afternoon once again, ladies and gentlemen. Allow me at this moment in time to introduce to you the session chair for this afternoon evening, Dr. Wangusi, the District Health Officer, Bari District, who's here to take us through this session. So Dr. Wangusi, you are most welcome. So you can greet your panelists. They are already seated here in front of you. And they're all yours.
Thank you.
Enjoy the session.
Yeah, thank you, Overall Chair. Good afternoon, ladies and gentlemen. My name is Dr. Jonathan Wangisi. I'm the District Health Officer from Mbale. It's a privilege to be standing before you. I've been requested to stand in for Dr. Ronald. I want to welcome you to this afternoon session on improved service delivery models. Friends, I want to assume that all those who want to be part of this session are seated. As you notice, we are supposed to have started at 3 o'clock. It is now 4 o'clock. So we are running 1 hour behind schedule. So we are going to cruise through. Fortunately, we have been helped by the absence of 2 presenters. We now have 3 out of 5. We have Dr. Mujenyi from Barara. Doctor, you're welcome. We have Kakanyero John Paul. And then we have Babire Lillian. Those are going to be our 3 presenters. I won't go into the titles of their presentation in the interest of time. As we did it before, we are going to be inviting the presenters and give them 10 minutes. We shall be flagging. You keep an eye on me because I'm going to be seated over there. And then after the 3 presentations, we shall usher them in front, and then we go into the question and answer. So without wasting much more time, I want to take this privilege to invite Dr. Mujenyi Godfrey to make his presentation. Let's put our hands together for Dr. Mujenyi. You're welcome.
Yes, good afternoon, ladies and gentlemen. I am Dr. Mujenyi Godfrey. I hope the IT is putting on the presentation. I come from Barara University of Science and Technology and Barara Regional Referral Hospital. I am a delegate of UHA Ankole. Thank you for sponsorship. And I'm here for respectful maternity care, and we are looking at how to integrate RMC into the healthcare system in Uganda. This work is done in collaboration with the SCAP department, the Reproductive and Infant Health Department of the Ministry of Health, World Health Organization Uganda, and of course UHA, and USAID FHI project. It's a work in progress. It started way back in April 2023, following a recognition. I hope the IT is sorting us. Is that okay? That's a different presentation. Sorry for that. So this work started in April following a realization of failure to achieve some of the goals in MNHC. And so we thought of integrating respectful maternity care into the Ministry of Health Quality of Care framework by innovating and forming the RMC or Respectful Maternity Care Integration Framework. Of course, the authors are people from the RMC landscape in Uganda. When you hear of RMC, you hear of things like, dignity, provision of care with confidentiality, free of mistreatment, informed consent. Basically care which is organized for and provided to all women in a manner that maintains their dignity, privacy and confidentiality. And this is what our dream would be when you go to a health facility. It ensures freedom from harm and mistreatment, enables informed choices and continuous, continuum of care, and it's achieved through effective communication between the sick person, the family member, and the community at large. And this care provided should basically be free from the 7 elements of the 7 negative elements, which include physical abuse, just a moment. The eyes are getting close to 50 years old, so some things keep changing. Yes, just a moment again. Just give me one more. That's better.
Yeah, as is trying to get the key points to reinforce the presentation, this is just an announcement. I want to let the delegates, I think some delegates think that there's another session in the Kama Hall. I'm not saying that you run away from here, but try to check the program and see whether you ought to be in the other Kama Hall so that you can also go and listen to those presentations. Thank you. Over to you.
Yes, care must be provided must be free from the 7 elements of physical abuse, non-consented care, non-confidential care, non-dignified care, including verbal abuse, discrimination, abandonment, and detention in a health facility for any reason. And we are aware that childbirth traditionally is, a social cultural event. Labor is associated with many complications, and health institutions must give a trade-off for desired care from what we want and what is traditional. Atkunda Esther et al. In 2020 found out that women still wish to deliver in a supportive, respectful, responsive environment that was loving. And women also say they should not only survive complications of labor, but also thrive and reach their full potential. And provision of RMC is a human right-based approach that reduces maternal morbidity and mortality. And in the background, we found out that there was absence of respect for maternity care, RMC, which contributed to the poor quality of care for women, newborns, children, and actually adolescents. there was continued disrespect and abuse during provision of this pregnancy-related care in Uganda, and the World Health Organization, in collaboration with partners, has developed MNC quality of care, standards encompassing the provision of experience of care, comprising of 8 domains of care, which many people know. And again, we found out that Uganda's maternal mortality rate remains high despite recent significant drops, because every mother that dies is a statistic, and we don't want anybody to be the number. Even if it reduced to 10, the 10 who die really stay the number and not the statistics. Thousands of women and newborns still die, and 17.2% are teenagers who are between 15 and 19 years old. These are young mothers with a full potential ahead of them. 95% of women, including adolescents, attend at least an antenatal care, but only 10% still, and 10% still deliver at home, which means that there's something that they are running away from our hospitals. That's 8 domains of maternal and newborn quality of care framework, where Uganda has done quite tremendously. Of course, first adopted it. They made strides in standards 1 and 2 and 3, which are health systems. Then experience of care, which is standard 4, 5, and 6. They perform poorly up to now, and these are the reasons. 90.9% of women are encouraged to adopt position of their choice during labor, and not only 10% in Uganda are asked a position of choice at birth. The rest we dictate. Lie on this flat couch, hold your head like this, without their participation. Only 38% of health facilities had a system in place to ensure all women are received and treated with respect and dignity. Only 27% of the health facilities were rated as having good practices of providing age-appropriate messages tailored to local needs for women, and about 54% of the health facilities were rated in their need for improvement. And this was a review in 30 districts, I think, by UHA in 2023. We went ahead to look at the local evidence. What is the document review? There were actually several stakeholders influencing RMC practice in Uganda for the last 5 to 10 years. But on the other contrary, all these stakeholders ended up with reports, bulletins, policy briefs, and we found out that nothing peer-reviewed was documented in the journals. Other countries had some documentations, but in Uganda, we found ourselves with nothing. And then RMC services would be delivered within the 8 WHO domains, which is an opportunity that is available for us. And I won't go into these standards because this is QI, I'm sure you know them. And we went ahead to find out the state of affairs in Uganda. There was no RMC roadmap, and there was a consultative meeting in April 2023. An RMC working technical steering committee was set up that encompassed the relevant people. There was hiring of an RMC consultant, a job which I took, and charged with the responsibility of developing an RMC intervention framework and the training manual. The overall objective was for the SCAP and RH department, supported by FHI, to really come up with the roadmap for RMC. We used the fishbone methodology to identify the root causes of disrespect and abuse of women, and for each identified gap, we coined a suitable recommendation, and information generated from this process was used to integrate RMC into RMNCAH quality of care in Uganda, and subsequently developed a framework and a manual to guide domestication of RMC in Uganda. And that's the fishbone methodology pictorial, where we found a lack of RMC-oriented healthcare services in Uganda. And we looked at the bottlenecks at the national level. We identified national level gaps, district level gaps, health facility gaps, and community gaps. What were the results generally? There were around 8 common causes of mistreatment, which included lack of RMC intervention framework and RMC manual to guide practice. And there was no approved charter or policy documents to guide practice. There was inadequate human resource for health, poor RMC-oriented governance and leadership, inadequate infrastructure and funding for RMC, lack of media engagement. There was lack of RMC knowledge among health unit management committees, lack of water, hand wash facilities, and adequate space for toilets and bathrooms in the facilities. And so, what are the conclusions or the lessons learned? And of course, the steps taken. We thought it is important to integrate RMC into MNH quality of care framework, and this will empower healthcare workers and health facilities to deliver quality RMC services to women and newborns with dignity. And I'll just ask for an extra minute or a minute and a half. What's done so far? RMC intervention framework and its monitoring and evaluation framework have been developed. They have been validated and approved by the RMNCAH Technical Working Group for the Ministry of Health, and they are at the level of approval. And once these documents, including the training manual, are approved, then they will be considered for use in the guiding practice in everyday life. Little snapshot on the framework. The goal is to ensure all women, including adolescents and newborns, receive dignified, respectful, high-quality care during pregnancy, labor, and postpartum period to improve health outcomes in Uganda. It has 4 strategic goals: to provide guidance on strengthening health systems at all levels, to integrate or domesticate RMC into healthcare services in Uganda, to strengthen the knowledge and skills of all healthcare providers, provide RMC-oriented services, pre and in service, to improve the capacity for all healthcare facilities to provide RMC integrated services, and to create awareness or empowerment of the community members to demand RMC services. The intervention framework is in place. It's structured like that. The stakeholders are all outlined in there with their roles, and it is available if you need a copy to make any input, because it is not yet approved. And I acknowledge the SCAP department of the Ministry of Health, of course the Reproductive Health and Infant Child Health Department, USAID, FHI for funding this work, and UHF for sponsoring me to come and share this with you. I thank you and bless you.
Yeah, That was Dr. Mjenyi. Please let's put our hands together and appreciate him a little better. Thank you for the wonderful work you're doing. Actually, we look forward to its scale up. Ladies and gentlemen, our next presenter is going to be sharing with us on the usage of VISTEC CD4 lateral flow assay, semi-quantitative test to improve on advanced HIV disease management in the Bidibidi refugee settlement, Yumbe districts. Please put your hands together and welcome John Paul Kakanyero. John, you're welcome. 10 minutes, please.
Thank you so much. My name is Kakanyero John Paul. I work for International Rescue Committee in Bidibidi Refugee Settlement. I am a medical laboratory assistant. That's mean I hold certificate in medical lab. However, I'm also a diploma student at the moment. I need to acknowledge my co-authors and other colleagues, other affiliations, organizations. Today we are going to discuss about the usage of VISTEC CD4 lateral flow assay semi-quantitative test to improve on advanced HIV disease management at Bidibidi Refugee Settlement. Yeah, Bidibidi Refugee Settlement is the biggest refugee settlement in Uganda and in Africa, and is the second largest refugee settlement in the world. It is located in Yumbe district, West Nile, northern Uganda. The next, this other one, photo there, that is the aerial view of the refugee camp. Now, you find in sub-Saharan Africa, that Uganda is inclusive of it, you find a third of people who are starting ARV treatment, or the clients who have left care because of one or two reasons. Most time presents with advanced disease, and they are really at high risk of mortality. So we have this strip you can see at the corner there that we use. Now, this strip is the same like normal rapid kit we have in our facilities. The normal kit are qualitative. It tells us whether it is positive or is negative. However, this one is semi-quantitative. It tells us whether the CD4 is above 200 or below 200. Now, for us, we focus on using these particular test kits to improve on advanced HIV disease in health facilities offering art services in Bidibidi Refugee Settlement in Yumbe District. Now, what we use a cross-sectional study designed where we reviewed the CD4 test that we have done on people living with HIV, targeting all health facilities that are offering art services in Bidibidi Settlement. We target, while we are targeting people who are starting treatment or already on care, and we did this project for a period of 5 quarters, that is 1 year and 3 months. And the key intervention that we put in place was, one, we mentored facility staffs that include laboratory team, art team, clinicians, the counselors. After mentoring them on how to use these test kits, we also distributed these test kits using the hub system with support from IDI. IDI is the one leading us in covering hub system in West Nile. Then we had periodic support supervision that was well facilitated by IDI. This one was not only implemented in Bidibidi Refugee Settlement, it was implemented in the whole district. However, I was overseeing Bidibidi Refugee Settlement. And now, afterward, we analyzed the data 2 quarters before the interventions, 2 quarters after the interventions. Then we presented it into a graphical manner that we shall see in the results. Here is this other first photo. That is me when I was doing on-site mentorship in one of the facility in Zone 3. And this other one is when I was doing technical support supervision and follow-up in the Bangatute Center 3 in Zone 4 in BDB Refugee Settlement in Yumbe District. Now, if you are to see, the 60 and the 75% was before we introduced the strip into the system, and the 92 and the 96% is when we introduced the strip into the system. The 85% was when there was stock out of this strip. However, as I talk right now, I'm very happy that all the facility has the strip, and we at 87% as I talk of now, with the goal of us reaching 100%. This next graph tells us out of 100 people that we tested, 77.2% had CD4 above 200. Meanwhile, 22.8% had CD4 below 200. And these are people having advanced HIV disease. Now, we registered a very great improvement from 60% to 96% on CD4 uptake within the BDB refugee settlement. And also at that time, we tested 561 clients, their CD4 using the strip. Out of that, 128, which makes around 22.8%, having CD4 below 200, and 433, which makes 77.2, had CD4 above 200. Now, what, of course, the target, as you're quite aware, HIV does not kill. However, it works on your immune system. Now, after working on your immune system, the opportunistic diseases come and knock you down. So, the leading cause of death among HIV clients is TB and meningitis. So, those people who had CD4 below 200, we tested them for TB LAM and serum crack, and they were managed appropriately. Now, the lesson we learned is this particular strip here, it is really very, very good for early detections of advanced HIV disease, being it is very simple to use and it's a user-friendly technology. Apart from that, when the uptake of CD4 strip is considered, you realize that it helps in timely interventions and it enhances overall improvement of advanced HIV disease management among people living with HIV in the resource-limited environment, which talks about it is covered a bit in our theme of today. Now, in our conclusion, we realized that this using this strip did not only improve on the testing of CD4 alone, however, it also improved on the uptake of TB LAM tests and also serum crack tests. Now, apart from that, we realized that this CD4 test kits is really very good, and it can really help for decentralizations of CD4 screening in the resource-limited environment, especially in health centers that do not have access to CD4 machine. You find out that most health center 3 and health center 2, they don't have the CD4 testing machine. However, this strip can be distributed to them, and it can really help them to improve on advanced HIV disease. Besides that, we realized that this particular strip, it really prompts on the management of advanced HIV disease at lower health facilities. Now, our key recommendations are the Ministry of Health with and implementing partner should organize for trainings and mentorships for health workers to improve on the decentralizations of these test kits, if possible, countrywide in the actually lower facilities. Apart from that, we need to involve the lay health cadres. When I say lay health cadres, I mean the nurses, the counselors, those who are not technical enough in the part of diagnosing, actually the laboratory people, so that they can use these test kits in lower health facilities. I need to acknowledge key people. One, International Rescue Committee that I worked for, particularly Dr. Patience. I know she's online following me right now. We acknowledge your effort. We also need to acknowledge UNHCR, our donor at the moment. We have other donors, but UNHCR is the biggest donor at the moment. We also need to acknowledge Yumbe District Local Government, our QI focal persons within ASEA. They have really done a lot of work as far as QI is concerned in Yumbe, including the regional QI team. I also need to acknowledge the Ministry of Health. I know they are doing a lot of great work. I also need to acknowledge IDI. There's Madam Salama and Dr. Nelson. They really did a lot of work as far as this project is concerned. Then lastly, I need to acknowledge Uganda Medical Laboratory Technology Associations. That is the association that I subscribe for. Thank you so much. In case of any questions, I'll be available. Thank you.
Thank you. Thank you, Paul. Friends, a bigger round of applause for John Paul. Thank you for sharing the experience of Yumbe District. Now, last but not least, ladies and gentlemen, we are going to hear from Babire Lilian. She is going to share with us her experience on improving resource mobilization in civil society organizations through capacity building interventions in Uganda. Lilian, you're most welcome, and you're good to go.
Thank you, Chair. Good afternoon, ladies and gentlemen. My name is Lilian Babile. I work with the Infectious Diseases Institute in Makerere. This afternoon, I'm going to share about improving resource mobilization in civil society organizations through capacity improvement interventions in Uganda under the theme of health financing. I acknowledge my co-authors. In sub-Saharan Africa, up to 20% of health spending is allocated to HIV services, with over 85% of the funding come through international donors. This is not different in Uganda, with only 3% of the GDP allocated to HIV services for at-risk populations. In October 2020, after the implementation of the Key Population Investment Fund project under IDI, we found that 10% of the civil society organizations had funding to continue with implementation of HIV services, and the rest could not sustain the project interventions because they did not have any funding to continue with implementation. To improve resource mobilization at the civil society organizations, PEPFAR through CDC supported IDI in resource mobilization capacity building interventions for civil society organization staff through training and post-training mentorships. How this was done, between November 2020 and December 2022, our team conducted resource mobilization trainings for 134 CS4 staff from 62 civil society organizations in 11 regions in the country. These trainings focused on development of resource mobilization strategies, development of organization income generating activities, resource mobilization plans, proposal writing, and among others. Quarterly post-training mentorships were conducted by the team to offer additional support to CSOs in areas where they are still challenged and support them in development of some of the proposals that they are working on. Data on proposal submissions, this is after 6 months post the training. An assessment was conducted, and the data was entered in ODK, Open Data Kit, on number of proposals that the CSOs had submitted and the number of proposals that were awarded. And we also picked qualitative data to back up this information. The data was analyzed in Excel, where we looked at percentages of the proposal success rates for each of the CSOs in randomly selected CSOs that were 35 from the 5 PIFA regions. So we found out that 5 civil society organizations had achieved a proposal success rate above 49%. Those are the ones highlighted in green. And a few of them were still struggling after the training that had below 15% proposal success rate. Overall, 524 proposals were submitted by the 35 civil society organizations, and of these, 36% were successful. The 5 CSOs that scored above 49% are those highlighted, and we also found out that 4%, there was a 4% increase in the number of CSOs funded by more than one donor. As seen from the introduction, majority of the CSO initially had only one donor, but after this training, we saw that there was that 4% increase of those that had more than one donor funding the HIV services. Resource mobilization trainings improved proposal outcomes from 10% to 36% in 2022. However, trainings without post-training mentorship limits the performance. And CSO staff were trained, but we also found that some CSOs are still struggling, and those scored 20% below the success rate. There is still need to support CSOs in donor mapping and linking them to donors, because these are mainly the areas that they are struggling with. We learned that the trainings in resource mobilizations improve civil society's ability to apply for and get funding for their activities. And investments in resource mobilization play a vital role in ensuring continuous flow of resources for sustainable community-level programming focused on key populations. That link is just someone sharing with us some of the lessons learned, and these people that had the highest proposal success rate, so they were sharing with us their success and what they've learned from the trainings. In conclusion, different CSOs will need different interventions based on their strengths and weaknesses, and poorly performing CSOs should be supported through startup of quality improvement approaches. We asked that the implementing partners should offer tailored resource mobilization trainings and continuous mentorships to indigenous civil society organizations to be able to improve resource mobilization. And to the CSOs, we request that should develop and monitor the resource mobilization strategies, focusing on resource mobilization planning, donor mapping, assigning responsibilities, and setting targets. And lastly, to the implementing partners, and the IDI CSO mechanism should support CSOs in donor mapping and proposal writing. I want to acknowledge our funders, CDC, PEPFAR, and Infectious Diseases Institute. Thank you.
Yeah, thank you so much. Members, I think she deserves a louder round of applause, Lillian. I think, Lillian, you can stay in front and maybe step in front there as I invite the other team members. Ladies and gentlemen, we've come to the end of the presentations. We've had this evening 3 presentations. The first was from Dr. Mujenyi. You saw the RMC model or framework that they piloted in Mbarara. Dr. Mujenyi and Paul, you can come forward, please. Then we also saw from John Paul the experience of using the CD4 lateral flow to detect advanced HIV disease in Yumbe. And you've just seen from Lillian the ability of implementing partners to support our civil society organizations to be able to live and sustain their programs beyond the projects that have been supporting them. So I'm sure you've been taking notes. I'm going to ask somebody to come and volunteer to move the mic. Okay, my sister over there. So it's now question or comment time. But because we are many, we shall limit to 1 or 2 questions, a question and a comment, so that we involve as many people as we are here to hear from as many people. So we can start to 1, 2, 3, 4, 5. Let's first take these 5. Okay. Number 1. You skipped number 1. Number 1 is here. Okay. Let's start. Number 1, let's start from here. 1, then 2, 3, 4, 5. Then I'll move over to this side. Yeah, you pose a question and direct it to the, be specific, please.
Thank you very much, our presenters, for this session. My name is Kasada. My question goes to the presenter of this quick CD4 lateral flow technique.
Yes.
Thank you for the presentation and bringing it to our attention. You know, Uganda is among the low, resource limited countries. So we were wondering if this intervention is really effective, like how we have seen, and there are strategies to scale up to other districts and the lower health facilities, because we see it can deliver great impact within our community. Thank you.
Thank you. Number 2, over the other side. Yes, the 2 ladies are 2 and 3.
Yeah, thank you so much. My name is Irene Nachilija, and my question goes to Dr. Mujenyi, just to thank him for championing dignified care to mothers and their children. The key thing is that we needed to know the characteristics of the 27.3% of the health facilities that were providing good, the respective maternal and child practices. We needed to know, are they BMOC facilities? Are they CMOC facilities? Could they be government? We needed to know more about these facilities. Then the other, we've seen a lot of efforts in having this respective full maternal care into the in-service practice. How is the experience on the pre-service training to health service providers? Thank you.
Okay, number 3, your neighbor.
Good afternoon, ladies and gentlemen. My name is Joanna Kazi. I work for AMREF Health Africa on the Heroes for Gender Transformative Action Program. I would like to thank the presenters this day, and more so Dr. Mujenyi for the RMC framework. I just have 2, 3 things to put across. One is, as he presented, there was a statistic, I think on the first slide, right after quoting maternal mortality ratio. There is something about young people
teenage,
that I think had either from UNICEF. So was it age group that 10 to 24? But he read it as a year of 10, 24. I'm just seeking clarity. If you could look at his slides. 2, there is something that was mentioned on this has been approved for use, but I'm just interested to know what is being done to cascade this to lower level facilities outside those that were it was piloted. And then lastly, is this initiative focusing on only public facilities and not the privates? And what is being done to integrate now that it's been integrated in routine services? Are we looking at only private? Are we looking at only public, or both? And what is in progress regarding that? Thank you.
Okay, number 4. Number 4. And then 5, then we cross over.
Thank you. My name is Ronald Mangeni, and I work with Baylor. My question goes to John Paul on VCTech uptake. One, you know that there's been reported challenges on interpretation of results for that kit, which is highly dependent on the strength, color of the test bars. So the question is, do you have you participated in any quality assessment scheme to ensure that the results provided are accurate? Thank you.
Okay, that's a good one. Number 5.
My name is Kamudsha Peterson. Thank you very much, all the presenters. I want to specifically go to Mr. John Paul. I thank you so much for matching today's theme of innovation. I want to just find out whether this is your innovation or it is a supported innovation from somewhere. You kept on saying, I did this. So I wanted to feel motivated whether I could also do the same thing. Then lastly, maybe since this is a new finding to some of us, you could also share with us about how reliable or how effective it has been found, such that we could say every result that comes out of it is true. We don't need to conduct another test or something of the sort. Then maybe another small thing is, does the ministry and the department concerned know of this innovation? Thank you so much.
Okay, thank you. So, okay, let's have him, then we cross over. Just keep noting, Doctor, the team, the presenters. We just want to wrap up the questions and then we go into your feedback.
Yeah, thank you. I'm called Edgar Tusuvira. My question goes to Honorable Lillian, who presented about resource mobilization for the civil society organizations. I saw that in some instances, the failure rate for those that submitted proposals was actually a little bit higher. Could the factors be related to the capacity built within those, or there could be other confounding factors? Thank you.
Okay, let's see, by show of hands, the people willing to, 1, 2, 3, 4, 5. Okay, let's take from number 1, yeah, 2, 3, 4, 5. And then I think that is a fair sample.
Thank you, all the presenters. My question or comment goes to Lillian. I'm Gordon, I work with GSCRC. And thank you for supporting the civil society organization to get resources. As part of your post-training mentorship, I was wondering if you have been actively engaging, one, in identifying possible funding sources in terms of RFS for these CSOs. Two, if you have actively supported them in the review and submission of their proposals. Thank you.
Okay. Number 2 on this line is your neighbor there.
Thank you. I'm called Justin Komakech. I work for LPHS Lango. Yeah, I'm asking for the case of BDBD. Paul. You are testing approaches, community versus facility, and how were you able to reach, especially the non-suppressed clients who may receive their first IAC from the community with those ones with viremia, but also your approach at the facility, laboratory testing versus point of care testing, like by the counselors at the counseling room. And then your challenges, why you were not able to reach 100%, especially along the way. Where did you encounter challenges, then mitigation measures if available? Thank you.
Okay, your neighbor, number 3.
Thank you so much. I am Magoa Lilian. I work with Lira District Local Government. My concern goes to my brother who presented on the Visitech. Of the numbers that you gave us that you reached so far, I would like to know of those ones were children also among. Thank you.
Okay, thank you for being brief. Number 4. That gentleman, the number 5. You're actually bypassing him near the camera. Oh, there.
Thank you, Chair. My question goes to the presenter Visitech, the CD4LFA. My concern is on the issue of the source of this equipment. To you, it looks like you were actually the source, and the facilities receive them from you. So, you know, my worry is always you IPs, you put sometimes these innovations above our bar. Above the bar, to the extent that even
please
our
be
mother, the
precise.
Minister of Health,
Be precise. Above the bar.
cannot reach it. So,
be precise so that
tell us the direct source of this tool or equipment.
Okay, thank you. Number 5. Number 5, just around here. Yes, I think that is our final Q&A.
Yeah, this is the final one. My name is Francis. I work with Chai Uganda. My question goes to Lillian, the CSO. It's related to what someone asked about the RFAs. I was wondering, in your the mentorships or follow-ups, if you support the CSOs to co-fundraise, since some of these CSOs actually have similar interests, so to avoid issues of duplication. And then the other thing is on whether you have mechanisms for accountability, because some of these CSOs are under the umbrella of not-for-profit, but actually the individuals, the interest is more of money-making. So if they put these resources into the right use. Thank you.
Okay, thank you. Please come over. Dr. Mujenyi has a question, much as he was
I have a microphone here.
Where?
Can I use it?
Where?
Here. I have
oh, you
one
have?
here.
Okay. Sorry. But Doctor, you go ahead, please.
Yes,
I'm
I also have a
absent-minded.
question to my neighbor, Lilian.
Yes. Please go ahead.
Yeah, I'm asking not as a presenter, guys,
as
an academician here. We have realized with a lot of concern that many implementing partners spend a lot of funds, and the funds are spent, the period is gone, but the evidence is not documented. And the documents that we are talking about are peer-reviewed publications, which will last a long time. We see a lot of bulletins and reports, closure kind of agreements, but when you come later on to review the evidence of what happened, and I had an experience with this respectful maternity care. I found White Ribbon Alliance was here. A lot of projects had done work in Uganda, but you go in the literature, you search and search and search and come up with nothing on RMC in Uganda. So to what extent are you prepared to partner with at least the academicians? These long-term projects should have attachment with the universities, with the master's training, with PhD scholarships, so that these students become the foot soldiers and they document evidence on behalf of the money holders so that we do not look as if we are not an academic-led community. I ask you for a comment. Thank you.
Okay, maybe before they can respond, let me field two questions. Paul, you really showed us about the VSTEC and its ability to pick advanced disease. And you said that led you to the TB LAM and the serum CRAG. But because you are linking that to advanced HIV disease management, you did not show us of those, what was the numbers of TB LAMs and the serum CRAGs that besides the differentiation, how many the TB LAMs and TB and serum CRAGs were conducted? And then to Lillian, somebody has talked about the fatality rate. I wouldn't say very high, but of course, I'll look at your intervention impacted. But I would want to know, for those that failed, what additional support have you been able to provide to these CSOs that, and maybe what could have been the underlying issues that affected their competitiveness during the RFS? So back to you people. I will start with Dr. Mujenyi.
Yes, thank you for once again giving me an opportunity to share. I want to make it clear that the goal of the RMC intervention framework is to purpose it to be integrated into routine practice in the healthcare system, reaching 90% of healthcare workers in 90% of BMOC facilities and CMOC facilities by 2025. If at all we are lucky, the ministry takes it up. In 2-3 years, we hope 90% of healthcare workers in 90% of the public health facilities. I am bringing out this to answer the question of saying, is this RMC thing a private or a government facility thing? We actually noted that in private facilities, there is a little bit of respectful maternity care. They call it a little bit of customer care because there is an exchange of money. And if you do not hold me very nicely, in a respectful way, I will take money to the next shop because it's my choice. So this thing we are talking about is not an assessment of private facilities. It is an assessment of government facilities. The BMOC and CMOC sites in our country, the National Referral Hospital, Kawempe, you know, the regional referral hospitals, or the 14 were assessed. No, some of them, because the assessment was in 30 health facilities in the whole country. And so it's not a private thing. This is what is happening. Some of the facilities are actually doing well. From the assessment, we thought we would have got, you know, nothing, but most of the facilities have at least a starting point. So you asked, Irene asked about the characteristic of the 27% of facilities. The reports are available. They are very big. If you want a connection to the reports, we can avail them for you. But some of these facilities, like 25%, 27%, had something to show off. Of course, 54% had more or less lacking elsewhere. RMC services for in-service, the people who are in service, because of the experiences of training here and there, they have at least something to offer. But we are visibly not teaching this to our nursing, midwifery, nursing schools, medical schools. So in this intervention framework, there is a very big component for pre-service to integrate it in the curriculum, and then finding out the partners who are engaging the training facilities, and at the same time, engaging those ones who are already in service. So it's comprehensive. Someone asked about the statistic of 17.2%. It's the contribution of maternal death. 17.2% of the maternal deaths we are occurring in Uganda are occurring in young people who are aged between 15 and 19%. It looks as if it is an average of the age bracket. But no, 17% of maternal deaths were contributed to by women who were 15 to 19 years. And these are people who are actually not supposed to be in the labor suite. So it means that we are offering them delivery services instead of offering them other services elsewhere, like education and empowerment and things like that. So there is a lot that needs to be done. I think basically those are the areas that were asked about, but I'm available for further discussion along the way. Thank you.
Thank you. A big round of applause again for Dr. Mjenyi. John Paul.
Yeah, thank you everyone. I am really very impressed because I think a few of you, it is their first time to hear about this test kit, and after answering some of these questions, we shall, I think, be at the same table. I want to start with the big man that I didn't indicate the number of TB-LAM or serum crack done. I think I should. If you see in the second, the second graph in the results, it says that we had around 128 clients with CD4 less than 200, and all those people we did TB-LAM and serum crack for them. And I even further said that they were all properly managed. Okay. The second thing was about, which I really brought issue, is about the quality. Yes, I am a laboratory patient. I take quality seriously. So what did we do to ensure that these test kits are of quality? We have CD4 testing machines within Yumbe district. And before we even use the strip, we had to do internal quality control. And how did we do that? We tested the CD4 using the machine versus the CD4 using the strip, and we realized that it was working well. And before it being introduced in the system, it was done quality control and it has passed, quality assurance, and it has passed by the manufacturers. This woman bring me now to where is the source of this test kit. Yes, this test kit has been introduced by Ministry of Health. The first supply we got was from Central Public Health Laboratory. Currently we are getting it from National Medical Stores. Then this one brings me to a question that how can it reach other facilities? As long as you are in a government facility, please make your order via National Medical Stores, then you have it available. In case using it is a challenge, please, you either read the leaflets, or I can even give you my number, you call me and explain for you in detail how it is used. This one also brings me to another question that I was more talking about. I received these strips were from myself, no? You know, I think the strips are not from me. And if I said most of the thing was maybe I was concentrating on how the implementation was, the strategies, because sincerely in BDB refugee settlement, I was taking charge and ensure that I mentored those teams. I ensure that the strip reaches everyone, and I followed through support supervision that everyone is using to improve on advanced HIV disease management in BDB refugee settlement. However, the district lab focal persons and the hub coordinator, they concentrated on other health facilities that are not within BDB refugee settlement.
Paul, are you done with the questions? Because our time is running
Okay,
out.
just, my questions were kind of many.
Okay, it's okay. But just
then, to summarize, a colleague asked what were the challenges that we faced. Yes, we faced, actually they stocked out of the strip. There was a breakup when CPHS supplied. The National Medical Stores had not yet started supplying, so we had stock out. That's why if you see in our graph, there was a reduction in the percentage, and currently as I talked, we have improved. There was also a question on if children were captured. Yes, children were captured. However, children below 5 years are not
they don't use this particular strip, but a child of 6 years and above, yes, we capture them as long as they are the targeted team to work on. Then someone also asked whether this was very effective because it is, you use your eyes to interpret. If you see currently in lower facilities, most of the tests are visibly interpreted. You mean you use our eyes, especially the malaria RDT. If he now says we don't use this strip, that means we should even stop testing malaria using MRDT. So this strip, as long as you follow the SOP, it is really very, very good. And I request that if the whole country can take it up, especially those in lower facilities without this strip, please, it can work very, very well. Thank you so much.
Okay, thank you. Thank you, Paul. And then over to Lydian for your feedback.
Thank you, everyone, for the questions and the comments. There was a question on the CSOs that did not have a high proposal success rate. We had 8 CSOs that registered below 10%, 10% and below proposal success rate. And for these ones, the major issues were around their resource mobilization strategies. We looked at the resource mobilization strategies, but they were not good enough. They had not, for example, they had not assigned responsible people to do the resource mobilization, and no one was accountable for this task, and also donor mapping was a challenge. So we've supported this. We continue to support them by ensuring that we share RFAs. We have our WhatsApp platform with all civil society organizations in the country. So we share these RFAs through that platform, but also on the emailing list. We've also started using coaches. These are CSO staff who are good in proposal writing, who have supported their organizations well, to train other CSOs and support them in identified gaps. Doctor had a question on whether we are involving the academician to document our work. At Infectious Diseases Institute, we are under the Makerere University. We closely work with academicians, and we work with different fellows, scholars, to be able to publish our work and also document the interventions. But we take note of that, Doctor. The other question, I think the other question was related to the proposal success rate. And post-training mentorships. So we support them in post-training mentorships. And when we realized that we had some that are not yet to task, especially those that did not achieve above the 20% proposal success rate, we've identified a team, a TOT team, that is going to support the CSOs in the reviews of these proposals before submission. That's it from the question.
Okay, let's appreciate Lillian. Thank you. Ladies and gentlemen, on behalf of the conference secretariat, I want us to once again give a big round of applause to our presenters this evening for a job well done. And thank you so much for being a good audience. I just want to end this session at that. Thank you so much. God bless you.
Yeah, you can remain seated because we need to appreciate this team. You see, presenting in the afternoon, after lunch, usually is very hard. But let's join our hands to applaud this team, who have, especially Dr. Wangusa, who has ably accepted to chair this session. A big hand clap for him. And then for the panelists, JP, Dr. Godfrey, and I heard they called her Honorable Babili. One of the person who said Honorable, I don't know, maybe she's a Honorable, we didn't know.
MP to be.
Yeah, MP to be. Yeah. So thank you so much for that. Now, as you're fearing the hot seat. No, you can enjoy the hot seat, so it's no longer hot. You can just mute the mics. Now, just a few administrative briefs. First and foremost, I want, may I request, I want the organizing team just to stand up and clap for these colleagues, for the delegates. Let's appreciate the delegates because they have been awesome and they have really participated up to this time. Yeah, we have come to the end of day one, and we have tea. However, I know we had limited time for the poster presentations, so I'll request the people who are presenting the posters can come. As people go for tea, you can continue the posters because we have some posters at the tea area as well as in this auditorium. That's one. Two, tomorrow we are beginning at 9. Whether we are 2 or 3, as long as we have the session chairs, we are beginning at 9. We have a very important keynote address of Professor Handa Yujiro, who is from JICA. I'm not sure whether he has flown in or he'll be online. So he's already in. So what I know with the Japanese, they are very time conscious. So let's do the needful. Be here by 9. We start off with that presentation from him with a keynote address. And we have another one also, another presentation which will be exciting by Dr. Esther Karamaji Nkoro from USID for that morning session. And then we shall have the discussions and the break. So we shall have different breakaway sessions still as per program. And of course, the secretariat is going to work very hard to make sure that the presenters are notified once again, reminded, so that they're here in time, so that we have a joyful day 2. Let's appreciate the IT team. They have done us well, at least when you're on the mic and you don't have to strain your voice, so let's give them a hand clap. And also a hand clap to the hotel, in spite of the hiccups in the morning over Yaka, because at least they have managed our nutritional requirements and we have managed the day well. So we hope those things don't happen again. So God bless you. Let's go for tea. And those of you who would want photo shots on this banner, you are free. You come and take selfies because they will be needed for accountability. Whoever sponsored you to this conference. So thank you so much. Let's enjoy the tea. Yeah. And the conference chair and the organizers, we shall have a small brief meeting just to recap of what has happened and then to plan for tomorrow better. Thank you. The poster presentation, the presenters can be around, and so that members, when they come, they are able to, you are able to explain to them and the like. In case you have any challenge, lost and found, you missed something, please let the secretariat know so that we can address your concern. Otherwise, we expect you to be in this place and stay well, healthy, and safe. Entebbe is a good